Hello, everyone. So my name is Jennifer Hefner, and I'm an assistant professor in the Division of Health Management and Policy and the College of Public Health at Ohio State. And my colleagues are here with me today, and they are from Nationwide Children's Hospital and the Ohio University. We cross institutions, and we'd like to thank Simon Lin, who's our senior collaborator, who works across these institutions also. We're going to talk to you today about using deep learning in risk stratification. So our objectives with this project were to develop a deep learning model approach to pediatric patient risk stratification, and that we could use to improve methods of risk stratification. And we also wanted to foster a collaboration between Nationwide Children's and Ohio State College of Public Health. The goal was to bring machine learning to a policy audience. So the group that has been doing this machine learning and risk stratification work at Nationwide Children's can publish in the clinical informatics journals and get that known among other people who do your types of research. The question is, because we feel this is really policy relevant, how do we get this information out into a policy audience also? So those were the joint aims of this project. What we did was use a deep learning model to develop a predictive algorithm for future healthcare utilization. We used claims data. We'll tell you a little bit about that in a minute. And then we used our model to assess the predictive validity of our models against some other commonly used risk stratification models in a small pediatric data set. So why do we care about risk stratification? And this is kind of a policy and management question, which is where my interest comes in. So healthcare reform is pushing value-based purchasing. And what that basically means is that for a group of patients, the healthcare system or providers will be rewarded for the outcomes of those patients. So keeping them healthy is a main goal to save costs and to improve patient outcomes. So if you think of the patients under a healthcare insurance or health system, you can think of it as a triangle, and most of the healthy people don't cost much, and they're at the bottom. And as you go up the triangle, let's see if I can use there you go. As you go up the triangle, people are a little bit more at risk. If you go to the top of the triangle, they have multiple chronic illnesses and advanced critical illnesses. These people right here are 75% of the admissions. They're a huge percentage of the cost, but they're a small percentage of the population. So risk stratification is trying to understand as soon as possible who your patients are that are at highest risk, that you can coordinate their care and hopefully lower costs and improve outcomes. So the challenges in pediatric risk stratification is that commonly used models use predictive regression models, and that's an analytic challenge because of the sparse, multidimensional types of data that comes from insurance claims. And then state-of-the-art risk stratification models that are currently used by healthcare systems and insurance companies are traditional grouper models. They're labor intensive. They were developed with a lot of domain and expertise knowledge, and they were also developed in adult populations. So there's poorer predictability in pediatric populations, and they're also not as agile and able to adapt as your patient population changes. So deep learning, as we saw in the last presentation, can sort of leverage the complex data that's available in health information and electronic health record systems. And you can use predictive analytics to do an unsupervised learning approach, and that can be with automatic feature engineering. So the application of deep learning to patient-level risk stratification is a new avenue. It's showed some promise, but our work, we understand, is the first to apply deep learning to a pediatric data set and attempt to perform patient risk stratification. The study population for this the study sample for this work was from Partners for Kids. This is a large pediatric ACO, one of the oldest and largest in the country. As you can see from the graph of Ohio, patients come from 34 counties in Ohio. That's over 330,000 lives, and there's a large group of people who work within the ACO to try to understand how we can properly risk stratify our patient population to target them with care coordination interventions. So I'm going to turn it over for a moment to my colleague, Xianlong, who developed this deep learning model, to tell you a bit about the model, and then I'll come back and tell you about sort of the results and implications.
After pre-processing, we have about 120,000 kids, and the predictive model we use is using 2014, 2015 as the training data sets, and 2015, 2016 as the testing data sets. And can we go to the next slide? And for those of you who who are not familiar with the claims data, here's an example from the PFK data sets. And as you can see here, a patient is represented as a sequence of medical visits. And each visit contains a set of medical claims, like the asthma, the urgent care, the procedure, medication, and the corresponding attributes, like the place of service and the cost. The model architecture. So we first represent the patient as a set of medical codes. Here, the 0, 1, 2 represent the frequency of the medical code. We call that a raw patient vector. And then we project the raw patient vector into a latent space that represents the patient and then concatenate with the DI, which is a demographic information. That's a little bit too fast, but it's fine.
Oh, sorry.
We're still talking about the left-hand side. And then the right-hand side, we're using the similar terminology to project the visit vector into the latent space, and then the idea is trying to predict what the patient will have in the next visits, the medical codes, the medical events. And
here, do you want to just do it?
Okay.
It's
That button?
Yeah.
Okay. So the training objectives are to learn medical code representation that's good at predicting neighboring codes within the same visits, and learn patient representation that's good at predicting the neighbor visits. And this is a slide that shows that we can learn some meaningful representation of the medical codes, medical visits, and patients. As you can see here, we can definitely see some clustering effects of different kinds of medical codes. Like the left-hand side, we have asthma, depressed, and seizures that are kind of separated in the 2D dimensional space. And then the right-hand side, the high-cost and low-cost patients are kind of separated as they're different, and that kind of show that we can learn meaningful representation. And after we're obtaining the meaningful representation, we use it to predict patient hospitalization in the subsequent year. Okay, thank you.
So this is our first bit of results. We looked at the area under the curve as our primary evaluation metric. And up here, you can see 6 different models that we use. The first was a logistic regression using the demographic and utilization variables that are in the electronic health record. And that the area under the curve is 73%, and the little bit smaller area under the curve was using the clinical classification software, which is group-related medical codes that is traditionally used for risk stratification. And then the DXCG intelligence is another proprietary model that's used by PFK currently and other health insurance and health systems to do risk stratification. And then the last 2 lines are the deep learning model that was developed by our team. So that showed a 73.5% area under the curve, and then when you added demographic and utilization variables in to the deep learning model, we saw a 75% area under the curve, which is the highest under these different models that are currently in use. So slightly higher with fewer manpower inputs into the system. So another analysis we looked at is the financial impact of using this model. So the deep learning model can more accurately predict high utilization patients, and by predicting a risk for hospitalization and then looking at costs. And small improvements in the model performance can have a big impact. So while the area under the curve increased in performance was small, it led to millions of dollars difference in the ability to predict utilization. So this is illustrated up here. We used both models to select the top 1% and then looked at their combined actual cost. And the deep learning model had costs of $31.1 million for the top 1%. And then the current standard in use by PFK and others has predicted $26 million. So the deep learning model for the 1% of high-cost individuals, the ACO could potentially influence an additional $5 million in costs compared to their current risk stratification modeling. The strengths of this study was that we used an unsupervised learning approach that reduces human effort. It's also more agile to allow for frequent updates for constantly changing, improving model performance. And you can train the model on specific population cohorts, so you can get specific within the types of patients served by your organization. Limitations of the current study is a small pilot data set, so we're definitely going to need to rerun this model on lots of different variations of data. One of our inclusion criteria for the patient sample also led to some limitations. So we selected patients who were continuously covered under the ACO for 3 years, which could be a different type of patient population from their total patient population. So sensitivity analyses are needed around that. The policy implications. So we want to improve the ability of pediatric ACOs specifically, and other managed care organizations generally, to do preemptive planning for financial risk. The ability to improve future diagnostic prediction can lead to better assessment of provider performance, better patient mix considerations when you're talking about pay for performance metrics, more realistic resource planning if you can identify more accurately the higher cost patients, and that can allow for the very practical care coordination and the types of interventions on complex patients that keep them healthy and reduce adverse events. So our references and our paper is available online in the American Journal of Managed Care. You can see below here all of our other co-authors from PFK and Simon Lin, our senior contributor. And if you have any questions, we're happy to take them, or you can look up the paper and email any of us, and we'll be happy to talk to you about it.
I think we have just a moment for any questions, if anybody has for any of our three speakers.
I don't know where they were.
Yeah, if you can go to the microphone again, please. There's one on that side, there's one on this side. Only because we have people who are listening to it live streamed and it's difficult to hear the questions.
Hi, a question for the last group of speakers. Very nice talk, thanks a lot. I just wanted to ask about bias and transparency, right? So the deep learning models are even more inscrutable than logistic regression. So it seems like there's a real risk if you're talking about rationalizing resources that issues of bias, say if, associations with the zip code, if there are patients in those zip codes that traditionally have underutilized resources, that could be propagated forward unfairly. I imagine you're probably familiar with these issues. Can you just say a little bit about how you're thinking about that?
Definitely. Do you want to go first or do you want to?
Okay. So definitely that is a limitation for deep learning, and on the other hand, it kind of, our approach is really taking in everything and then identifying those that are grouped in under that high-risk category. And we do have, so this is not entirely just data-driven. So obviously, with our PFK partners, they have care coordinators assigned. There are certain ways that you can actually evaluate and try to gain insights from those ones that are selected by the deep learning approach.
So I think the one thing to add is we did have these discussions with the reviewers of our manuscript. And if you look in the manuscript, we do have a discussion about future directions. And I think one important one is to, as we include social determinants of health data into electronic health records, and specifically patient-reported surveys and outcomes, we can then incorporate that into the deep learning model. So right now, a lot of the features of that you're speaking about are not reflected in electronic health record data. But as that becomes more common, and there are certainly in the larger EHR vendors that are starting to collect those types of social determinants data, we can include that in the modeling, which is what's so interesting about the deep learning being agile in that sense.
Others? Well, thank you to all three of our speakers. Very exciting work, and thank you for sharing with us. Yeah. Do I need an operator?
Yeah, just turn it on.